as well as some of the disease sites less likely to participate. But here are really our most prevalent physical needs that we saw in Nova Scotia. So you can see here fatigue, very high levels of fatigue in after treatment for many of these disease sites. But sexual function in terms of prostate cancer, very high as well. So almost 70% of men with prostate cancer reported high needs in sexual function. This is pretty similar to the national data set. These were the two most prevalent physical needs in the national data set as well. Where actually, if you look nationally, I think 80% of survivors reported physical needs. And you can see that a minority of people, 18.5 to 31, so a minority of survivors sought help for all of their physical needs. And I'll just show this one. This was Nova Scotia, and what we saw, so we've actually looked at a lot of this data in Nova Scotia. And what we've seen in terms of emotional needs, again, worry about recurrence is quite high and is the highest sort of emotional need in most disease sites. But again, around prostate, changes in sexual intimacy was reported as a very high need by close to 60% of our sample. And fewer people actually seek or sought help for all of their emotional needs. We asked a whole lot of questions, and many of you may have seen this survey already. But when we asked about responsibility for follow-up care, you can see that it varies by disease site. So in blood, for example, so this question was essentially asking respondents, survivors themselves, who's responsible for your follow-up care? And you can see that blood cancers, very few would say primary care is responsible. For the most part, it is their hematologist, their specialist. And a smaller proportion, maybe around closer to 30%, say both. But you can see breast cancer, for the most part, say both folks are responsible. What I wanted to say here, point out that I've called it shared care or both. My word is shared care. I don't think that was the word on the survey. But what I want to point out is this is just asking folks who's responsible for your care. This doesn't mean we have some sort of planned, coordinated, shared care model here that we're doing. When we ask them around confidence in primary care, for the most part, you can see the blood cancers there, survivors of blood cancers, less confident that primary care understands what they need when it comes to their follow-up care or can take care of their needs. But certainly for the other cancers, and you can see colorectal there quite high. This is the interesting part. And so when we looked at self-reported quality of life, self-reported physical health and emotional health, to try and understand if these outcomes differed across these, I'm going to call them models of care, but essentially if primary care was responsible, if specialists were responsible, or both, we saw no differences at all in any of the outcomes. So this is consistent with what the RCTs, the randomized controlled trials, have been showing us for more than 2 decades. That for many sort of low-risk survivors, again, I don't want to say all because it's absolutely not all, but for many folks, primary care is probably the appropriate place to be. I think now the challenge is, and this was a paper published in 2013, but I mean, I really think now the challenge is twofold. It's how do we identify those patients or those survivors where primary care really is the most appropriate place versus those that may have higher needs or higher risk where coordinated shared care approaches or even maybe oncology-led care is really what is needed. And then how do we best support those transitions or best support shared care approaches? So for people that are transitioning to primary care, how do we provide the services and supports that are needed to enable sort of smooth transitions, coordinated transitions? And for those people who might require shared care, how do we make sure we do that in a coordinated way where there's role clarity, people understand what it is they're responsible for, they communicate with across the team well, and so on. So how do we design really more personalized sort of risk or needs-based follow-up care to better meet survivors' needs after treatment? So I'm going to speak for a few minutes about one tool that was endorsed, probably the next 5 or 6 minutes, about one tool that was endorsed in 2006 by the Institute of Medicine to improve patients' experiences and outcomes after treatment. And that is a survivorship care plan. So I feel like everybody on the call will know what that is, but if not, it's a written, they don't have to be written, a written or an electronic document that really contains a summary of the treatment that a person received, plans for follow-up care, ideally the division of responsibility among different providers and so on. And since this was endorsed in 2006, there's been at least 8 RCTs, and there could be more published now, but as of maybe a year ago, there was at least 8 RCTs internationally that were conducted on survivorship care plans. And many of them have been null, so there's been no impact. But I would say mixed results is probably the most optimistic way to describe it. So I've thought a lot about survivorship care plans, having been involved in the very first trial that was conducted across sort of the 9 sites here in Canada, and that was largely null. And I'm sort of thinking, so what's the deal, right? Are these plans truly ineffective? Are survivorship care plans truly ineffective? They've been widely endorsed and widely implemented across the country, across the world. And so are they truly ineffective? Are we wasting money and resources? Or might they be effective in some ways and not others, right? So I want to get into some work that I've been involved in that has looked at some of this. So this was a study that was led by Sarah Birkin, which was at UNC. And what we were interested in, we did a number of things here, but what we were really interested in was, one, the implementation of survivorship care plans and how they're being implemented. Because as with any intervention, you can have an effective intervention, but if it's not implemented well and people aren't using it, you're not going to get the desired result, right? And then the other thing we were interested in really was, are the randomized control trials, so this is this paper, are they really assessing the outcomes that people would expect from a care plan? Are they assessing the outcomes that are actually relevant to various stakeholders? So we undertook this study, again, it was qualitative, interviews with a whole host of stakeholders in survivorship care, in 3 kind of health centers, I suppose, or sort of jurisdictions, 2 in the US, 3 healthcare systems, 2 in the US and here in Nova Scotia. And what we found really, I'll go here, you don't have to read all of this. What I'm trying to say here is there are a number of overlapping outcomes. So our stakeholders, who are oncologists, nurses, primary care, survivors, caregivers, administrators, so on and so forth, our stakeholders talked about a whole bunch of things they would expect from a survivorship care plan. Some of those overlapped with what was actually met with what has been measured in RCTs, and some of it didn't. And in fact, if you look at the RCT outcomes here, so one of the primary outcomes of many of these RCTs is high-level health-related quality of life. Not one person in this study across 3 different healthcare systems said that they would expect their health-related quality of life to improve because of a survivorship care plan. The outcomes that they described were much more, I would say, proximal and maybe process-oriented than quality of life, but nonetheless, they were important outcomes. We grouped these outcomes into sort of 5 different categories, if you will. So enhancing communication and role clarity, meeting educational and informational needs, and those are educational and informational needs of survivors and their caregivers, as well as the person who's responsible for follow-up, if that's primary care or if that's someone else. Mitigating fear and anxiety, improving capacity for self-management, and here you have this health system one. facilitating efficient discharge to primary care. This is another study that a medical student of mine published last year, I suppose, in Current Oncology. So Amanda was really interested in sort of the decision to adopt or to use sort of tools in clinical practice. So she was a medical student and interested in cancer. So we looked at how people make decisions and the role of evidence, so the role of sort of high quality evidence, RCT evidence, and so on in people's decisions to actually adopt and use different tools. Relevant here is the fact that well, we talked about survivorship care plans, but really is that these survivorship care plans were often used for reasons that were not necessarily related to improving people's quality of life. They were used to improve role clarity. They were used to sort of keep to communicate information, to keep lines of communication open between primary care and specialist care, and really to facilitate and to support the transition of patients back to primary care. Finally, this is work that another medical student of mine did on the transitions data set, cancer transitions data set that I just talked about, that large survey that happened across the country. And what she was really interested in was the receipt of a survivorship care plan, but whether outcomes, self-reported outcomes, might differ based on whether people received one or not. And it just ended up being in our Nova Scotia sample, it was nearly 50-50. So 50% received a survivorship care plan and 50 did not. And what she found when she looked at these data were that respondents who received a survivorship care plan had significantly better outcomes. So they were all significantly different for all 5 of these. So for stating that they received follow-up cancer care that met their needs, information was available when they needed it. They received the care and support for their physical, emotional, and practical concerns when they needed it. I think the lesson here, what I'm trying to get across from all of this work, is a couple of things. I think for researchers, or the lesson here from the survivorship care plan work is I think that for researchers, we need to pay more attention to the outcomes, I suppose, that we assess, and then what we might truly expect from a particular intervention. Again, I was interested in that study that was led by Sarah Birkin, that nobody mentioned quality of life, health-related quality of life, yet that's the outcome, primary outcome that most of the RCTs were assessing. And when I brought that to my Survivor and Family Advisory Committee, so the folks who advise me in my work, in my survivorship work, the response was, well, of course, like why would you expect sort of a piece of paper to impact your quality of life? That doesn't mean it's not valuable, and that doesn't mean we don't want it. It can do a lot of good things, but it's probably not the thing that's going to impact my quality of life. So despite not doing that and not impacting people's quality of life, it might be that survivorship care plans do actually have an important role in survivorship care. In terms of addressing informational needs, maybe some other unmet needs, improving role clarity, and sort of facilitating transitions from, again, sort of intensive primary cancer treatment to sort of post-treatment, to care post-treatment. But I think we have to remember they're a tool, right, that probably needs to be used, if they're going to be used, alongside a more comprehensive survivorship program. So I want to switch gears a little bit, and I've got about a couple of slides left, so I should be done in 4 or 5 minutes. But I want to switch gears for a little bit. I'm going to put my implementation science hat on for the last part of this talk. So survivorship care, we know, happens in a sea of competing demands and priorities. These are some CBC media articles from the last year or two here in Nova Scotia, where there seems like there's always sort of challenges in terms of providing, or there's often challenges in terms of providing sort of maybe care close to home, timely access to care, and so on. certainly in terms of covering some of the high cost of cancer drugs today. And every now and then, things like this happen. So this is a picture of the hospital that I work in that a number of years ago completely flooded, and the ceilings came down from the weight of the water in one of our ICUs, in our palliative care unit, and so people just had to rush to get patients out. And of course, right now we have COVID going on, which thankfully is not something that we've dealt, that we're going to deal with all the time, or not something that happens often. But again, there are competing priorities and demands in the system. And my point here is to say that oftentimes those people who work in the system are experiencing so many demands as they work in an environment, whether they're trying to administer the system or oversee the system, or whether they're working on the front line. They're working in an environment where all kinds of urgent things are happening. So survivorship care is not always top of mind. And it's not always a priority. And I think that's something important in terms of the work that we do in survivorship. We all know it's important. And, we all know from survivors themselves and family, like, we understand that. But amongst this whole host of other demands and priorities, it doesn't always come to the forefront. And so my colleagues and I from across the country are writing up now, actually, a manuscript on a CCSRI funded study that we had, where we were investigating the sustainability of 25 cancer survivorship interventions that had been implemented across Canada. And one of the things we found was that organizational and system level priorities with respect to cancer care were really a necessary determinant to the sustained use of these interventions. So if survivorship care was and remained a true priority in the organization or at system level, then they were much easier to sustain the interventions after that initial funding. But really, for the most part, the sort of low priority of survivorship care compared to other areas of cancer, right, compared to the treatments and diagnostics and so on, as well as sort of the shifting priorities over time. So survivorship care may have been a priority in 2015, and then a new government came in and it's no longer, or whatever. They're really major threats to sustainability. And I think we all know that, obviously, but it's sort of something to point out in terms of all the work that we're doing in survivorship. So my key messages here in Nova Scotia, and I know this is true across the country because I've done a lot of cross-country work on this as well. So true in many provinces, that many survivors continue to see their oncology teams for follow-up care. At the same time, and this is where I think we need to do better. So there's increasing healthcare use, which I don't have a judgment on that. That may very well be needed. But there's no evidence that we're doing a whole lot better to meet survivors' needs despite that increased use, at least here in Nova Scotia. And so I think that more personalized follow-up is definitely necessary for two reasons. One is to sort of optimize and to improve patient outcomes, experiences and outcomes, but also our health system outcomes. And to end, I think that decision maker involvement, and this is why I sort of talked about leading a lot of this work with decision makers. I think decision maker involvement cannot be underestimated in all of the work we do, but particularly here in cancer survivorship, because survivorship is often not a system priority. And I think that patient engagement is similarly critical. So I think that we need to know as researchers where we can make the biggest impact in someone's life or in their lives. What is it that's meaningful and relevant to people themselves as they sort of navigate a new normal after treatment? So here are my acknowledgements and my research staff, my students that have worked on a lot of this, the Nova Scotia Cancer Registry, who's always answering my emails and telephone calls in a timely fashion and always willing to help me with all of my work. Ardith, who was one of the clerical staff, she's retired now, but at the Halifax Cancer Care Center or Cancer Center, who dug in the weeds with me around all of this, around around how their data are captured and so on for such a long time, and my survivorship or survivor family advisory committee. So I'm going to leave it right here if anyone's interested in looking at this, and I'm available for questions or any discussion.
Great, thank you so much, Robin. That was excellent. So we have about 15 minutes here for questions. So
are there any in the chat now? Do you know, Cynthia?
No, there's no questions in the chat right now. What about folks over the phone or over audio?
Robin, can you hear me?
Yes, I can.
Hi, Robin. This is Richard Wasserseck out in Vancouver. Your work is fabulous. It makes me somewhat sad that I left Dalhousie. You'd be such a great colleague to work with.
Thank you.
So I know that in these type of groups, the men are a small subset of the people in attendance, and they often talk far more than their share. So I want to apologize up front for this, but I think there's an issue here that's intriguing, and I'm actually starting to study it. We have a manuscript we're writing up right now on who accepts the term survivor. So, for instance, if you're looking at who accepts survivorship care plan, if a person isn't comfortable with the label survivor, then they're not going to be comfortable with the care plan. So, for instance, and I think this is worth exploring. I'd love to talk to you more about it. Maybe we can arrange a time just for that. But, so I've been starting to work with breast cancer patients, having worked with prostate. And actually, prostate cancer patients overall dislike the term survivor. And therefore, if someone offers them a survivorship care plan, they may say, well, I don't feel like a survivor. I'm not ready to go back to my GP. I don't feel like a survivor. On the other hand, breast cancer patients love the term. And in fact, just to hint at it, we wanted to know whether this was a sex gender thing or a disease thing. So our study that we're just finishing up, we're just writing up now, we looked at male breast cancer patients to find out whether they lined up more with the prostate cancer patients or with the female breast cancer patients. And all this centers on the term survivor. And it may be that the real issue is acceptance of that label. And I'd like your thoughts on that.
Yeah, so you know what, that's interesting. I've asked, so I would say only in the last 5 years or so, maybe longer, I actually ask people now if they're comfortable with that term. So for example, this Survivor Family Advisory Committee, our very first meeting, one of the first things on the agenda was, are you okay with the word survivor? Because if not, let's figure out a different word, right? And everybody was, so that's why we call it Survivor Family. There's a number of family members on there as well.
And how many prostate cancer patients were in the group?
It's interesting. There's no prostate, but it's half, but it's half men. There's brain, testicular, and so, but there's no prostate. Yeah.
Well, I would love to talk to you more about this.
But I'm certainly aware of, much more attuned to that now. I have to say, a decade ago I probably wasn't, but now I am, and I do say to folks, I'm using this term because I don't know of a better one per se, but if there's a better one for you, let me know what it is.
All right. So please email me. Let me know when we can talk.
Yeah, I'll email you after. Yeah.
Thanks.
Thanks so much, Richard. Do we have any other questions from the group?
I don't have a question. This is Jennifer. I just want to thank you, Robin, for a really wonderful presentation and so much to think about in this. And thank you very much.
Thank you. Thanks. I hope it was somewhat understandable. Someone said to me earlier today, I was on a different call about something completely different. And I said, you get so passionate about your stuff. That's what I feel when I start talking about this.
Well, it certainly comes through, and I like that. It's great. It makes your presentations very appealing and engaging. So that's.
Thanks.
In the absence of anyone else talking, I want to throw out one little anecdote, because I had the experience of talking to two patients who were dismissed, graduated from their cancer care, ready to go back to their GPs with a survivorship care plan in hand. It was fascinating. These were over a 24-hour period. One of them bragged to me about how she was refusing to get out of her oncologist's chair until the oncologist agreed to continue seeing her. She was a breast cancer patient. And her feeling was that her GP was too late getting her into the oncological stream and was therefore the reason why she had such an extensive care in the oncology setting and didn't want to go back to her GP. In the same 24 hours, I was talking with a young Hodgkin's lymphoma patient who had a clean slate after multiple chemo treatments and got her survivorship care plan and wanted to take it back to her GP, who had just noticed this lump on her neck out of the blue, which she hadn't gone in to even be seen for, and got her into the oncology setting so soon, so quickly, that she was essentially cured. She wanted to take the plan back to her GP's office so we could frame it and hang it on the wall. What it says to me is that it absolutely depends on the relative trust that the individual patients have in their oncologist versus their GP. And that's going to dominate everything, I think.
I would agree completely.
Yep.
So
how do we deal with that?
When I, in that initial, pardon?
How do we deal with it?
So in my initial, I'll talk a couple of things. In my initial work that I put up, the very first quote earlier, and that was around sort of the transition from, again, sort of intensive care to sort of survivorship or follow-up care. But also we talked about the role of primary care. And to tell you the truth, and this was more than a decade ago, or about a decade ago now, things have changed, I think somewhat. But there were so many, particularly the breast cancer survivors, who basically, one person said, well, if my daughter married my surgeon, right? So they still want access.
I love that.
Yeah. And a lot of responses were very similar, right? Like, well, if you want to send me back to my family doctor, my daughter, only if my daughter marries my surgeon. And it was that sort of response, and I remember that. And what was interesting was that in the colorectal group, there was a bit of a different sentiment. And one of the things that we sort of probed about and started to try and figure out why the colorectal seemed much more sort of okay for the most part about going back to primary care as long as all supports were in place and so on, was that when we were chatting with collecting data and having these focus groups with the colorectal survivors, it was recognizable that they were describing a different experience during their cancer treatment, where for the most part their oncology teams were communicating back and forth with primary care, and they knew that they were. So they knew their primary care provider and their team had some sort of a relationship and communicated, right? The breast cancer patients or survivors really weren't describing that, and not saying it wasn't happening, but they weren't aware of it if it was happening. And so I think part of it is that I think you're right. I think it's trust in the individuals, but I think it's also part of it, trust that your primary care physician can actually connect with and communicate and contact your team if it's needed, right? Or when it's needed. So that there's a supportive relationship there. So I think that supportive relationship and the trust that your specialist team or your oncology team and your primary care team can communicate. I think there's ways that us in the system, I think we can do that. I think there are various different tools and mechanisms that we could put in place to try and ensure that happens. I'm not saying they're all easy to do, but there are things. Now, when it comes to individual trust in your physician, absolutely. I think that for the most part, all the patients and survivors that I've talked to for more than a decade, for the most part, very few exceptions, but have a really tremendous trust in their oncology team. And that makes complete sense because, they've been cared very intensely by this team and have interacted with this team, for months, if not longer, if not years, and have a really sort of deep, intense, through a very emotional time for most people, right? So they develop these really close sort of relationships and trust in their team. And I think with primary care, you're absolutely right that I think that for the most part, we look at primary care as a place where trusting relationships are built over time and longitudinally, but that's not always the case for everybody. And certainly if there were issues with maybe a delayed sort of referrals or delayed diagnoses early on and stuff like that, and they perceive their primary care maybe didn't do as well, or their provider didn't do as well as they should have, then there's going to be trust issues going back.
Bravo, thank you.
Hi, Robin. This is Jackie speaking. Thanks so much for your great presentation. It was so nice to see the evolution of a lot of these studies over time and how well connected they are, and love your the narrative approach that you always take to talking about your research. So that really resonated with me. I just wanted to have one follow-up point and ask a question. And one follow-up point is just to say that in some of the research that I've done in breast and thyroid with respect to patients' perspectives on various follow-up care models, overall, the takeaway really seems to be is, the need for reassurance that regardless of the model, they need to be reassured that they're going to be getting quality care.
Yes.
And I think one of the questions I've been having more lately when thinking about family survivorship care and perhaps earlier transition to survivorship care are twofold. And one is, I'm wondering if there's any research specifically or insight on as to standards of time for transition to follow-up care. I mean, I know each cancer site has sort of ideals, but from the patient perspective, from their perspective, after what point? Is it the 5-year point that they would really feel most comfortable transitioning? 1, 2. I'm also wondering whether or not, given the whole suite of health issues that GPs have to deal with, do they have time to manage an increased onslaught of cancer survivorship care in their practices?
So great question. So around the timing of the transition, there's different, I don't think there are standards around it per se. And anybody correct me if I'm wrong, I don't think there's actually standards per se. I think that many of the oncologists here would think that 1 year after might be a bit early for some of their survivors, if they're still dealing with sort of late, like long-term physical effects or something like that. I do know, and refer back to that one of the studies when I talk about expectations, I do know that the oncologists here that do transition back to primary care fairly early after treatment, within 1 to 2 years after or less than that, sorry, 1 to 2 years after diagnosis. So let's say treatment's over by 6 months or something like that, are following or transition back within maybe a year after treatment. And they, again, talk about expectations, but they talk about it in that this is not a survivorship care plan. This is your care pathway. This is your plan. We're going to deal with this. You're going to get this treatment. We're going to do this. We're going to do this. When it's over, we do the, testing and so on to make sure everything's gone. And then, you go back to primary care as long as we're, happy with everything, and frame it so that primary care, again, is where you're supposed to go back, like where you're going, because that's where you're going to get the best care, right? So it's the framing and the sort of expectations up front. And in just chatting with those oncologists, my sense from them is they don't experience a lot of panic from their patients, because again, right from the beginning, this has been the plan, not a survivorship plan, but the care plan, right? Now I know that I would say here in Nova Scotia, we are trying to transition people back, sort of more low risk, low needs, people back to primary care within 1 to 2 years, not 5. Although there's people still being seen certainly at 5, but it's earlier than 5. Mm-hmm. The other thing I would say related to that, but also related to sort of what Richard was saying around survivor and the word survivor, is that in the work that we had done sort of here and down in UNC and in Kaiser, so the 3 different healthcare systems around survivorship care plans, it was the patients or survivors themselves that we talked to that said, I don't understand why it's a survivorship care plan. Like, this is my care plan, and this should all be like communicated and dealt with and discussed at least from the very beginning that I go into a cancer center or a clinic, right? So again, it's sort of this is not just a survivorship care plan, this is my whole care plan. And I think that if we did that and reframed it a little around that, and again, taking the experience of the oncologist here around timing, that maybe we would be more successful in terms of then sort of transitioning people back to primary care, or to more of a shared care approach with sort of clear roles and so on. In terms of the time of family physicians, but I understand what you're saying, and then a part of me wants to say, but they're seeing them anyway, right? Like, there's so many visits. Like, when I look at visits here, and I know that Cynthia's on the phone, she's done a bunch, she's published a bunch recently around sort of primary care and specialist visits for breast cancer, but in 4 or 5 different provinces across the country. And primary care use is quite high in this population anyway, and probably is in outside sort of cancer populations. But you know, their family docs and their nurse practitioners and so on are seeing them quite a lot. So I think they are providing the care in a way, or they could be better supported to provide it even better. Do you know what I mean?
That's a really valid point. I'm thinking of debates I've heard at these conferences that really sort of target family physicians, and having that be the 2 sides of the coin. But that's a very good point, that they are there already. I'm just noticing that I may be taking us over 2 o'clock, so I just wanted to let you and everyone know, and I'll shut off my mic for Jennifer Athena to take over.
Okay, all right. I was going to say, even during treatment, we always think, we hear people say, I've heard here in my province anyway, family physicians say, well, we lose them during treatment. We don't know what's going on and so on. But in work we've recently published in 4 different provinces, we've actually saw primary care use is like highest during treatment for breast cancer.
So interesting.
Okay. So thank you, Robin. We're just after 3 o'clock right now, so I think we'll end things there. So I just want to say thank you so much for a great presentation, and to everyone who attended today and for the excellent discussion. So we'll end it there. Everyone take care and have a great weekend.
Yeah, thanks everyone. Have a great weekend.